Thank you very much. As Fred said, yeah, this is the second lecture we're giving for the perioperative medicine lecture series, and we are. I titled mine Lecture 1 because there will be two lectures that address pulmonary perioperative issues, and the Lecture 2 will be given by Dr. Marilyn Griffin. So this is number 1, and I'll just jump to the first slide. So to touch on three topics, and as you might expect, there's too many topics to actually include, but we have to choose the ones that are more common, that we see the most, and we're definitely seeing a lot more of obesity-related issues in the perioperative period. We see a lot of obstructive sleep apnea, and we always get called to manage patients with hypoxemia. So those are the three topics that I'll be discussing today. So starting off with the obesity topic. I came across this slide as I was preparing the lecture, and it definitely called to my attention what severity of the problem the obesity is. We look at these maps and we can see how the problem of obesity has progressed in only 20 years. We're not talking about 50 or 60 years, we're talking only 20 years, where if we look at Massachusetts, we were less than 10% rate of obesity in 1990. We increased to 15 to 19%, and now we are in the 24% of patients with a BMI over 30. If we go to the southeast, let's say Texas, they were 10 to 14%. They were almost 20% in 2000. Now they're over 30% in obesity. So these are staggering numbers, and what's worrisome is how fast this problem has occurred. So we all know, I'm not going to spend too much time on this slide, but we all know that obesity has a lot of medical problems that complicate it or are associated with it, from heart disease to diabetes to stroke, hypertension, the metabolic syndrome, which by itself is it's a big consumer of healthcare dollars. So all these are significant problems, not touching the problems that we see in the perioperative period. So how do we define obesity? By BMI is usually the way we do it, and we classify overweight as being 25 to 30 in the BMI. Anything between 30 and 40 is called obesity, and some people divide it into obesity type 1 and 2. And then obesity type 3 is what we refer to morbid obesity, extreme obesity, which is a BMI over 40. However, it's the classification of BMI for medical care purposes and research purposes has been found not to be very accurate by itself. And what's become more important to look at is the abdominal fat or visceral fat, and measuring the waist size in patients is what actually determines more of a patient's risk. And when I was reviewing the literature as far as trying to find out how much of complications obese patients may have post-operatively, you would be surprised to find that many studies do not show any difference in morbidities and mortality, or significant difference. And one of the critiques for most studies was that they were only basing it on BMI. So you can have a very muscular individual who has a BMI of 29, 30, 31, and would qualify as an obese individual, but they were not assessing abdominal fat. It's definitely been a lot of association of visceral adiposity with metabolic syndrome and chronic inflammation. There's also been association of visceral fat with complications like wound infections, AFib, and then there's also the waist to hip ratio has also been associated with cardiovascular mortality. So I think in the future we'll probably have to move from just doing BMI to actually doing the hip to waist ratio, waist to hip ratio, and somehow measuring visceral adiposity, so we can get exact data of the impact of obesity. This was, of many studies that I reviewed, this was probably the largest, but also retrospective, so a lot of flaws. That one of the few that did show some worsening of post-operative morbidity, mortality, and so there were a lot of patients, 7,000 patients. So there was higher prevalence of MI, peripheral injury, wound infection, UTI, and there was also a doubling of the mortality rate. So there, I think there's definitely some effect of obesity. We just don't have the studies to prove it because of what I just mentioned. So when we evaluate patients with obesity, one of the first things that worry us is, are they going to be difficult to intubate? And some of the factors that predict difficult intubation includes a large neck, a higher malempathic class, and previous difficult intubation. So this could be unrelated to obesity. The malempathic classification is pretty straightforward, very easy to see, and anybody on a physical exam can review it. So class 1, you can see right through the to the oropharynx, and class 4 you don't see anything, and class 2 and 3 are somewhere in between. That class 3 you don't see the tip of the uvula. So this is a good guidance to predict if somebody may be a difficult intubation, with 3 and 4 being definitely more worrisome. Some of the perioperative complications from obesity that have been described as gastric aspiration, aspiration of gastric contents, development of hypoxemia when patients are hypoventilating or are apneic, developing pulmonary atelectasis. Also, if somebody who is obese and has significant higher metabolic demands at baseline, at rest, if they are stressed under conditions of hypovolemia or anemia, fevers, they will have less ability to cope with those stresses. And it's also found that patients that are morbidly obese have longer recovery times from surgery. There's also high prevalence of sleep apnea. They have increased sensitivity to depressant effects of hypnotics and opioids. That sensitivity could be related directly to them having some degree of hypoventilation or apnea, but it can also be related to the fact that the volume of distribution for these sedatives, drugs that are used during anesthesia, and the narcotics we use post-op, those get distributed to adipose tissue, so that in order to get a good response, you have to load them with higher doses of narcotics, so that once everything starts redistributing to the systemic circulation, they actually can have more respiratory depression. And as I said, the risk of difficult intubation is higher with the higher malempathic class and large neck circumference. So one of the syndromes that is associated with obesity that not everyone, or actually only the minority of patients with obesity have, fortunately, is the obesity-hypoventilation syndrome. That's typically seen in patients that are morbidly obese, and it's characterized by hypoxemia and hypercarbia. So patients that have oxygen saturations less than 60, PO2 less than 65, which more or less is equivalent to a 90% SAT. So somebody with less than 90% SAT, or around 90, higher PCO2, would be considered as having hypoventilation. And this is an important test that I like to check. And anytime I see somebody who is having hypoxemia or respiratory problems post-op, I usually like to go to the preoperative labs and look at what their bicarb was pre-op. And if unless they were on very high doses of diuretics, which can cause contractional alkalosis, if they have a baseline bicarb higher than 30, that is an indirect indication that they could actually be having a chronic hypercarbia that is being compensated. So that's an important number to look at. So why does oxygenation get altered in these patients? So as you can see in this figure, the more pressure you have from the abdomen pressing on the lungs, that will cause restriction to lung expansion. That will decrease the functional residual capacity. So that means at the end of expiration, the volumes in the lungs are going to be much less. That'll actually predispose to getting atelectasis at the basis of the lung. If the lungs are smaller, then there's less oxygen stores in the lungs. So if you have less air in the lungs, and then you have a little bit of hypoventilation, a little bit of apnea, you'll desaturate much faster than if you had normal lung capacity. So, any patient in the post-operative period will be hypoventilated a little bit as they recover from anesthesia, but if they have very restricted lungs, then they have the reduced O2 stores, and they'll desaturate much faster. And these are just other considerations. COPD and obesity the combination of both can cause problems. We know venous thromboembolism is a big issue, and in the bariatric population, the highest cause of mortality post-op is PE and a 30-day post-op. So this is definitely a significant issue for obese population, especially morbidly obese population. And then the combination of COPD, obesity, and obesity-hypoventilation syndrome are risk factors for pulmonary hypertension, which can complicate hemodynamic management of patients who have surgery, get anesthetics, and have big blood losses. So what things can we do postoperatively to help these patients? Well, it's definitely important to always keep the head of the bed at least 30 degrees, if not higher, at all times, and not just immediately after surgery, but every single day. You want to keep the diaphragm and the abdominal contents of the lungs to allow better expansion of the lungs. You need to give effective analgesia, which it's easier said than done. You want to have them pain-free enough so that they can actually move and go to a chair and ambulate and cough, but you don't want to over-sedate them. So this word is, again, more easier said than done. Incentive spirometry, you have to try to give humidified oxygen. The humidified oxygen part is mainly just to prevent, to help with secretion clearance. You want to avoid high FiO2 if possible, because we know that the higher the FiO2, the closer it gets to 100%, the more risk of atelectasis you have. So you want to keep the SATs at least over 92%, but try to avoid high FiO2 if possible. Some patients will need the use of non-invasive positive pressure ventilation or BiPAP when they're too sedated. Of course, that would be used in the ICU. So I want to go to sleep apnea, which is related to obesity. The statistics on sleep apnea vary. You can read 20 different articles and chapters, and they'll have 20 different numbers of the rate of sleep apnea. And the reason is because a lot of patients have asymptomatic sleep apnea, and when they do studies on asymptomatic patients, they do come with these numbers. Not all of them would be symptomatic, but it's about 13% in men, 6% in women. One thing that is very constant is that doesn't matter what studies you see, there's always double incidence in men than in women. And the most concerning thing is that the patients that are obese with metabolic syndrome, they have at least half of them have sleep apnea. So if you have somebody who is obese, diabetic, hypertensive, hyperlipidemic, statistically they have a 50% chance of having sleep apnea. And this article was published in the England Journal this year, a few months ago, which is a rude awakening, preoperative sleep apnea epidemic. And so this is being recognized in many other places as being a really important problem where there's not a lot of research done. And the authors of this article, this perspective, stated that something that is pretty logical, that obstructive sleep apnea is more prevalent among candidates for surgery than general population. And I say it's logical because if you are obese, you have more comorbidities and more reasons to actually need surgery, like orthopedic surgery. So that's why there's more in the hospital than people in the general population. They do have increased risk for pulmonary complications, patients with sleep apnea. Their sleep apnea is undiagnosed in 80% of patients coming for surgery, and I think that's pretty true. I think most patients that come to surgery and that are noted to have apneic episodes have not been diagnosed before. Then there is also uncertainty as to what to do when you have patients that are suspected to having sleep apnea preoperatively. So let's say somebody gets referred to a pulmonary doctor and for possibility of sleep apnea, but the surgery is coming soon and the patient really needs the surgery. Do you cancel the surgery, send the patient for a workup, or do you just proceed with surgery and accept the risk? So it would make sense that you would cancel the surgery, do the workup, get the patient on treatment, and then do the surgery afterwards. But that doesn't happen most of the time, and even studies have not been done that show which is better. So we would believe that if you treat the patient first, they'll do better, but there's really no data. So that's one of the things that this perspective paper was bringing up, is we really don't know what the best thing is to do. The American Society of Anesthesiologists, they do have position that any patient that has obstructive sleep apnea should be observed during prolonged periods of time after surgery and should receive routine positive airway pressure. So that's their recommendation, but in fact only less than 20% of patients actually have that done. So it's a really concerning type of condition. It's very prevalent. If we wanted to go this route and we studied every single patient suspected of having sleep apnea, a great number of surgeries would have to be canceled, postponed, a lot of aggravation from patients, surgeons. So it's definitely a significant logistic issue with these patients, and unfortunately they are higher risk if you don't do it. So hopefully more studies will be done in the near future that will guide us a little more as to what is better to do. Of course, there are some patients that when we see them preoperatively appear to have a more severe type of characteristics of sleep apnea or hypoventilation syndrome. Those for sure we would not clear for surgery, but there are some that are more borderline, and those are the tougher to manage. So how do you define sleep apnea? You don't have to really pay too much attention to the descriptor, but an apnea is a complete obstruction of the airway. A hypopnea is a partial obstruction of the airway associated with some desaturation. And a respiratory-related arousal is just a term that we use for patients that do not qualify as having apnea or hypopnea, but they do have some respiratory-related effort that makes their brain aroused. So these three usually get measured during the sleep study. And for us to know how bad somebody's sleep apnea is, we count the computer counts the number of apneas with the number of hypopneas per hour. And if normally you should have less than 5 apneas or hypopneas per hour. If you have 5 to 15, that's a mild sleep apnea. If you have 15 to 30, that's moderate, and if you have more than 30, that's considered severe. And just to give you an indication, most patients in this range probably don't get treated, but when it's severe, and even within severe, you can have patients with an apnea-hypopnea index of 30 to 40, and there's some patients that have it up to 150. So there's definitely a wide range in between the severe cases. The recommendations is that you would treat anyone with moderate, severe, or mild if they have daytime hypersomnolence. So those are the cases that you treat. And the pathophysiology, you can see in this figure that air comes, either through the nasal passages, the oral cavity, into the trachea. And with sleep apnea, you have either a very floppy tongue that just falls back into the posterior pharynx, or you also have a lot of redundant pharyngeal tissue that obstruct the airway. So air comes to the nose and cannot go in, so it blocks the airway. So that's basically what obstructive sleep apnea is. A lot of things can do it, from having a thick neck, having redundant tissues, large tonsils, large uvula, posterior pillars are also, you can see them behind here. So you barely have a view of the oropharynx. So this would be somebody who would qualify as a myelopathy class 3, because you can see a little bit of the oropharynx, but this would be somebody that could be at risk of having obstructive sleep apnea. And we have two scales that we use for sleep apnea. One is to assess the degree of sleepiness of the patient. As I said, patients that have mild, moderate sleep apnea, you'll treat them if they have symptoms. So we use this Epworth sleepiness scale, and we ask questions as to if they would have a slight, moderate, or high chance of dosing doing these activities, watching TV, reading, driving, or stopping at a traffic light. So if they give us a number of whether they would be having any chance of dosing off during these activities, we add those here. And we think that if it's more, they score more than 10, they're sleepy. If they're more than 18, they're very sleepy. And definitely over 18, they should definitely get a sleep study. I think if they're over 10, they should get a sleep study. It would be recommended for them to get a sleep study. So this is a scale that we use. It's part of our intake forms in the office. But this is another screening questionnaire that actually is predictive more of the chances of somebody having sleep apnea. So it's a STOP-BANG questionnaire. And so it has 4 questions that are related to that the patient would answer from the past medical history, and 4 that you get objectively. Do they snore loudly? Do they get tired? Are they tired during the day? Has anybody observed them stop breathing? And do they have hypertension? So each of this would give you 1 point if it's yes. If you have a BMI more than 35, older than 50, neck circumference more than 40, or you're a male, then also those would give you 1 point. So based on this STOP-BANG questionnaire, and actually most of these questions we have them included in the in our H&P from pre-admission screening. So this information can be obtained, and it's a validated question. And we can see this study where if we're looking at just any sleep apnea over 5 of the AHI index, if you have a score of 8, you pretty much have 90% chance of having sleep apnea, and you have like 40% chance of having severe sleep apnea. This should be here 30, not 3. So the STOP-BANG questionnaire is definitely reliable. So the higher your score in the STOP-BANG questionnaire, the higher chances of having mild or severe sleep apnea. So it's very useful. What can you do? Not that this would help us in our setting, but weight loss is definitely important for improvement in sleep apnea symptoms. Exercise by itself, whether you lose weight or not, does increase obstructive sleep apnea scores in general. And the sleep positioning, a lot of patients may have more significant sleep apnea when lying supine, so adopting different positions, lateral, especially lateral decubitus, may actually help the sleep apnea. Avoiding alcohol and really anything that depresses the central nervous system is indicated, and it's definitely found that alcohol worsens sleep apnea, and also, yeah, the medication selection. So unfortunately, there's a lot of patients that have sleep apnea that their main complaint is that they wake up many times during the night. And so what they request from their physician is sleeping medicines. And all the sleeping medicines depress respiratory drive. So it's a catch-22. You want them to sleep, you want them to feel better, but if you just give them the sedation medication, then they'll sleep better, but their SATs will be worse, and they might not feel better the next day. So when I get that request from a patient that they're waking up too much, and I have, based on the sleepiness scale or the STOP-BANG questionnaire, there's a high probability that the patient has sleep apnea and they cannot sleep and ask for sleeping aids. I say I can give you a sleeping aid if we first do a sleep study. So I just don't go ahead and give them a sleeping aid. So that's important to consider. And also, quickly to review. So there's several ways of treating sleep apnea, and the most common is using positive airway pressure mask, and CPAP is definitely the most common one we use, which stands for continuous positive airway pressure. So you have a set pressure that is constant throughout the inspiratory and expiratory cycle. You have we call it BiPAP. It's a bi-level positive airway pressure. So you have a setting during inspiration which is higher, and a setting for expiration that is lower. So usually the BiPAP is chosen for patients that have more severe sleep apnea. And then you have the auto-titration positive airway pressure, which is a type of CPAP, but it will titrate to the patient's needs. So you can choose a range of 6 to 16, and the device will detect pressures in the circuit and vibrations in the circuit that tell the device that the patient is starting to obstruct, and the device will increase the pressure automatically to prevent the airway from collapsing. So this is probably the one that it's being used the most now on anybody who is recently being diagnosed with sleep apnea. And then there are some that are more high tech, which is it's an adaptive type of positive airway pressure, where you start with a very low CPAP level, and the machine adapts to any needs from the patient. So these are the main types of positive airway pressure that are used. And basically, what positive airway pressure does, it's an Air-Splint. You have this is a nasal CPAP. Air comes under pressure, and the pressure inside the airway prevents the tissues, the retropharyngeal tissues and the tongue, falling back and obstructing the airway. So basically an Air-Splint. Some patients will sleep with their mouth open, so they would need a full face mask as opposed to a nasal mask. But in general, nasal masks are better tolerated for most patients. The other second common option of treatment is the mandibular advanced device, which what it does, it has to be made by oral surgeon that specializes in sleep apnea. Not everybody can do it. And what it does, it pulls the jaw forward, so that if you pull the jaw forward, then the tongue will and other tissues will actually be pulled upwards, and then will keep the airway from collapsing. Now this is effective for the more mild to moderate cases of sleep apnea. But it is interesting that a recent study from this year showed that even though we know that CPAP is much more effective at relieving sleep apnea than the mandibular advanced devices, a recent study showed that it was a very well conducted study. There was equal effectiveness in markers of sleep apnea with both CPAP and this device, and the reason being that the compliance with this was much higher than with CPAP. So if you have a better treatment but people don't use it, and you have a less better treatment, less good treatment, but most people use it, then the end effect is going to be similar. And that's what this study showed, that patients in many outcome measures did pretty much the same with mandibular densify. So that study was first time that was shown, and actually that sort of changes the way we practice, because a lot of times we would just give up. Even on patients with very severe sleep apnea, we would give up, and they don't want to use CPAP. There's not much you can do, giving them oxygen maybe, but now with this, there's another option that you can entertain. And then surgical options. There are many surgical options. This is the most common one, the Uvulopalatopharyngoplasty, UPPP. And basically, they just come and resect as much tissue from the oral cavity and pharyngeal area as they can to increase the passage. Now, if you remember the picture we saw at the beginning, if the tongue falls back, and that's what is obstructing the airway, this surgery would do nothing. So most patients do have some component of the tongue obstructing the airway falling back. So this surgery should only be done for patients that really have a high malempathic class, and that you suspect that the tongue is not significantly involved. If you do this surgery for some reason and then you want to go to CPAP, they have more tough time tolerating CPAP after this surgery, so you don't want to just do it off the bat, but in some patients it can be beneficial. In general, it's recommended for patients with mild sleep apnea only. And this is just a curve, survival curve, so sleep apnea is definitely a problem. This is a 6-year span, so patients with sleep apnea compared to controls, there's a 10% difference in mortality. So if you follow a patient with sleep apnea, over time, 6 years later, 10% more chance of not being alive. So it does carry mortality. So what we can do here to help patients with sleep apnea, again, the head of the bed needs to be up. The more we can have the head of the bed, the less the tongue will fall back into the pharynx. We can also try to avoid the oversedation. And what I had mentioned with the distribution of medications in obese patients, you can have this late sedation from having used higher doses at the beginning. So you have to be careful with oversedating patients. And then if they have obvious obstructive apneas, you need to use positive air pressure. And in this institution, the policy is if somebody has never used CPAP before surgery, they're identified as having obstructive apnea, they have to come to ICU so that we can titrate the CPAP in the ICU. And so if in patients that have no history of sleep apnea, but they are desaturating, then you would want to obtain an ABG to rule out CO2 retention. You want to obtain a medical or pulmonary consultation, and you might need to transfer the patient to ICU. So if you see somebody who doesn't have a history of sleep apnea, but their SATs are dropping and there's obvious apneas, you need to make sure they're not retaining CO2, because that could be the cause of them hypoventilating, desaturating, and then you might need to monitor those patients in the ICU. So combination of apneas with CO2 retention acutely is definitely important to manage immediately. We recommend humidified oxygen in patients that have or have suspected obesity-hypoventilation syndrome. You want to avoid saturations more than 96%. That decreases the drive to breathe and also decreases VQ matching. So if you aim at SATs and then 99 to 100%, they will retain more CO2, so that's something to avoid. And again, looking at the bicarb level is important in these patients. some of these patients you either have to monitor in the ICU, or if if they're not having that much of apnea or CO2 retention, you can monitor them with a bedside oximeter for the first day or two after surgery. You can consider using the end-tidal CO2. And then indications for transfer to ICU. So if you have somebody who is having apneas, is desaturating, and doesn't comply with positive airway pressure, they definitely have to be observed in the ICU. If you have somebody desaturating despite treatment with CPAP on the floor, that patient should be also in the ICU. And anybody with serious comorbidities, somebody has significant coronary disease, history of recent stroke, chronic. I put in chronic kidney disease because these are the patients that are very tricky to manage as far as pain medication. They can hang on to narcotics for very long periods of time. So if you have sleep apnea and any of these comorbidities, also need to consider monitoring those patients in the ICU. So I'll go to hypoxemia, is the last part. When you read books about hypoxemia and how you try to pathophysiologically explain hypoxemia, this is what you find. This is the 5 ways that you explain hypoxemia in a pathophysiology point of view. I wanted to put it in a different perspective, and I wanted to use 3 different types of causes of hypoxemia. One is related to ventilation, the other one related to the lung parenchyma itself, and then vascular reasons. So the ventilation disorders, when we talk about ventilation in pulmonary medicine, we're talking about the transfer of air from the environment to your lungs. So is air going from outside to inside the lungs effectively or not? And there's many reasons why it could the flow of air could stop. One is the patient is oversedated and there's no breathing, so there's no movement of the chest, there's no ventilation or no in and out of air. If you have obstruction of the airway, like in sleep apnea, or if you just have hypoventilation syndrome, if you have a paralyzed diaphragm, then you're only breathing from one lung, not the other. Any other neurologic deficits can do it. So anything that decreases the ability of the chest to expand and will cause ventilation problems. More physiologic anatomic problems would be COPD, bronchospasm, chest wall restriction. So somebody with severe kyphoscoliosis, somebody who is morbidly obese, myasthenia gravis, any other muscular weakness. So the ventilatory disorders need to be categorized in a different area, because you can have 100% normal lungs, but you may have one of these things going on and you may be very hypoxemic. So this is important to consider as when you're looking at the differential diagnosis. When you look at disorders that affect the lung parenchyma, these are I would say the 5 main ones that you see postoperatively. So pulmonary edema, you're flooding the alveoli with fluid inside the alveoli or in the interstitium. Pneumonia, atelectasis, ARDS from either aspiration or TRALI, transfusion related, or the fat emboli syndrome can give you ARDS. And then pleural effusions, if they're big enough, they will compress lung parenchyma and will affect gas exchange. So the disorders of the lung parenchyma really don't have anything to do with air going in. Air is going into the lung, but the gases cannot exchange through the alveoli because there's something affecting the gas exchange. So all these are very common. And I highlighted the atelectasis because that's probably one of the ones we see the most. And then we have the vascular circulation ones. So again, you can have completely normal lungs. You may have no parenchymal disorder, but you may have a vascular obstruction like a PE, and you can have hypoxemia from that. Patients that have pulmonary hypertension may be more at risk of also being hypoxemic if you have AVMs or if you have intracardiac shunts. So this is something that would be something that would normally be known before surgery, but can be diagnosed afterwards. So I like this divisions of ventilation, lung parenchyma, and circulation, just to go through the differential diagnosis. So when we get called to see somebody with hypoxemia, what should we do? First of all, we should recheck the pulse oximetry. It's many times that I've seen that I've been called to see patients and they were just not capturing well. The probe wasn't capturing well, wasn't in the right position, or hands were cold. And so you just need to make sure that he's checking on another location, that there's no malfunction of the probe. And then because atelectasis being such an important cause of hypoxemia in our hospital, you need to check oxygenation at rest while the patient is lying down and when they are upright, and see if just getting them upright, it changes their oxygenation. And also assess it with ambulation. Most cases of hypoxemia that are related to true lung condition, atelectasis, pneumonia, or pulmonary embolism, CHF, if the patient ambulates, the SATs will go down because there's not enough ability for the lungs to transfer oxygen. However, if it's related to atelectasis or hypoventilation from obesity or big abdomen, then actually with ambulation they may actually get better, and we see this all the time. So testing the oxygenation upright and with ambulation is very important. And then just review the history. Is there some history of lung disease or heart disease that was not uncovered preoperatively? Make sure you go through all the lists of medications that the patient got postoperatively to see if there's anything that would depress their respiratory drive. Then the physical exam, level of consciousness. If they are obviously somnolent, then you would want to you would be considering hypoventilation as the source. Look at the patient's respiratory effort. Then check for airway patency. So you can do that by looking inside the mouth or auscultating the neck, see if there's any stridor. And then auscultation of the lung to look for crackles. And one of the ways I try to differentiate crackles from pulmonary edema versus atelectasis is you have the patient cough forcibly a few times, and a lot of times when it's atelectasis, the crackles will clear, and of course if it's pulmonary edema, the crackles will not clear. And the reason the crackles clear with atelectasis is because anytime you want to cough, you subconsciously are taking a deep breath before the cough. You have to generate enough pressure to cough. So when you're taking the deep breath, it relieves some of the atelectasis. So that's a way of determining if you're dealing with pulmonary edema or atelectasis. And these are tests that you would do in a progressive fashion. You can start with a chest X-ray to see if there's any obvious atelectasis infiltrates or pulmonary edema. You can proceed with a chest CT if there's any reason to suspect that somebody could have aspirated or have some underlying emphysema, pulmonary fibrosis that was not uncovered. If you're suspecting pulmonary embolism, especially if your X-ray is normal, then you want to think about a VQ scan or a CTA. These are regular labs that you would do an ABG in somebody who may be obese, have sleep apnea, or be hypoventilating, doing some cardiac workup with enzymes, EKG, and even progress to an echocardiogram if the picture is still unclear. One of the things that's important to know is that a lot of patients may have more than one etiology for the hypoxemia. So it's not, most patients will have atelectasis, but they could have other things as well. And the thing with atelectasis is that you can have atelectasis with a normal X-ray, and that is because you can have microatelectasis throughout the lower parts of the lung that are not big enough to show up on an X-ray. You just have units of alveoli collapse throughout the lung, but not a whole segment. So if you don't have a whole segment, then you don't see it on the X-ray. So I pretty much consider that everybody post-op has been in bed for 24 hours will have some degree of atelectasis, and most patients get opioid medications or sedatives, and most patients will have some fluid overload. So most of our patients will have these three conditions. So a lot of times it's a combination of factors, not just one thing. So you have them do IS, low threshold for diuresis. If they are very somnolent, you try to reverse opioid effect, use nebulized bronchodilators. That helps with secretion clearance. And if they can ambulate, that's one of the best things to help with this. This is a picture of an X-ray that has a little bit of both. So the patient has some amount of fluid in the fissure, so maybe a sign of mild fluid overload, and also linear atelectasis. So this is not an uncommon X-ray we see here on the hospital. This is a patient that comes, and this is just to give a case of a patient that, because they are recumbent, they develop atelectasis just by being in bed very long. So this patient comes on day 1. You can see the lungs well expanded. You can see the diaphragms very sharply. By day 3, you can see that the right side, it's still nicely sharply seeing the diaphragm, but you start losing the diaphragm on the left side, and by day 4, you pretty much don't see the diaphragm. This is a very common scenario in patients hospitalized, especially in the ICU, but any patient that does not move a lot will always have a left lower lobe atelectasis. Some people call it the left lower lobe syndrome in the ICU. Is the weight of the heart and the abdominal structures just compresses the left base, and then you just have an opacification. So once you have this, you really don't know in an X-ray, is it all atelectasis? Is there now some pneumonia? Is there some fluid? Unless you do a lateral view or a CAT scan. And if you do a CAT scan with this left lower atelectasis, this is what you'll find. In this case, there's a little bit of pleural effusion, and then there's some consolidated lung at the left base. But that's just an effect of being in bed in a recumbent position for long periods of time. This patient was hypoxemic, normal lung parenchyma. This diaphragm, it seems a little on the higher side, but the lungs are completely normal. So if you have somebody who's very hypoxemic and you have a normal lung, normal lungs on X-ray, that's when you think of PE, and that's exactly what this patient had. The VQ scan shows the high probability for PE with a lot of ventilation defects, and was probably confirmed with CTA, where you can see almost like a saddle type embolus here in the right pulmonary artery, and also a large embolus here in the left pulmonary artery. There were many other emboli. So, and this is a patient with normal X-ray. So a hypoxemia, normal X-ray, that's concerning for PE. So just some take-home messages for obese patients. Remember, keeping them head of the bed elevated, giving effective analgesia, aggressive and sentence spirometry, and this is, I know everybody gets it, but some patients you just have to be more on top of them to make them do that. Give them humidified oxygen, keep the SATs more than 92%. For sleep apnea, the same, head elevation, avoid oversedation, use positive airway pressure when apnea's hypoxemia is present. Consider transfer to ICU in these 3 scenarios: persistent hypoxemia despite CPAP, hypoxemia in somebody who is non-compliant with CPAP, or hypoxemia with severe comorbidities. And obesity-hypoventilation syndrome, remember, always suspected in somebody who has a baseline bicarb list higher than 30. It's not 100%, but it's not many conditions cause the bicarb higher than 30, so that's a good thing to look at, and avoid saturations greater than 96% in the obesity-hypoventilation syndrome. We already went through the hypoxemia. Just a few more things on the hypoxemia. So remember that most patients will have atelectasis. Consider the effect of opioid medication and other sedatives, even in the patient who seems fully alert. And this is important. So you can give somebody a normal dose of narcotics. They can be talking to you, but their respiratory drive is decreased. So you have to also take that into consideration. Have a low threshold to give a diuretic trial. choose a lower dose and see if that helps. If the patient's blood pressure doesn't tolerate, you can always give fluid back. And just check the oxygenation when the patient is upright and ambulating. And that'll help you determine if atelectasis is part of or hypoventilation is part of the syndrome. Thank you very much.